welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
Hello, and I'm Veronica Stancheva. I'm a student intern at the Blum Center.
Today's program is a special collaboration between the Blum Center and the Sexual Health Clinic at Mass General. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has music and hear a guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask a doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. All right, next I'm going to turn over to Veronica, who will introduce today's guest speaker.
Here we have Dr. Ard, who is the Medical Director of the National LGBTQIA+ Health Education Center at the Fenway Institute and the Director of the Sexual Health Clinic at Massachusetts General Hospital, where he's a practicing clinician and faculty member in the Division of Infectious Diseases. He is also an assistant professor of medicine at Harvard Medical School. Dr. Ard's interests include LGBTQIA+ health and the prevention and treatment of sexually transmitted infections and HIV. Please help me in welcoming Dr. Ard.
Thank you very much. It's great to be here, and I'm happy to be speaking on the topic of Mpox today. I'm going to go ahead and share my slides, and I very much welcome your comments and your questions, and so we will save time at the end to go over those. All right, so in this webinar, I hope to describe the Mpox outbreak, which began in 2022 and has continued since then. And we'll talk about ways that we can prevent and treat Mpox and things that I think are important for people in the public to know about this infection. But first, I want to begin with a note on terminology. Historically, the illness that we now call Mpox used to be called monkeypox, but this was renamed in 2022 by the World Health Organization. In truth, that original name was actually never that accurate. This illness was named in 1958 when the virus that causes it was found in laboratory monkeys in Copenhagen, Denmark. But the reservoir of this infection in the environment is probably rodents. It's not monkeys. So the infection and the illness and the virus don't really have much at all to do with monkeys. The WHO announced the name for this illness being Mpox in November of 2022, and largely the scientific community pivoted to using that name, although the US CDC has reverted to using the name monkeypox. There are two different strains or types of the virus that are also called clades, and those are called clade 1 and clade 2. Those were also renamed at the same time back in 2022. Now, the strain or the type of the virus that caused the outbreak that we have been addressing since 2022 is clade 2. So you'll hear me say that a few times, but I will also mention clade 1, which historically has been a more severe form of the disease. Now, because of this shift in terminology in the past few years, you'll see that some of my slides say Mpox, some that are from prior times, cite research where the term was monkeypox, but please know that right now we're using primarily the term Mpox. So taking a step back, and I'll talk more about the outbreak in a moment, but why did this really begin in 2022? And in retrospect, I think that there were a lot of conditions that favored the development of this outbreak. One of the main ones is that smallpox has been eradicated, which is good news. How is that connected to Mpox? Well, both smallpox and Mpox are viruses that fit into a large virus family called the orthopox viruses. And it turns out that a vaccination against one often protects against the other. So when the world was exerting a lot of effort to eradicate smallpox, there were many people who were being vaccinated against smallpox. And it turns out that those vaccines also protect against Mpox. And so once smallpox was eradicated, those vaccine efforts dwindled and then largely stopped. In the US, for example, people have not routinely received the smallpox vaccine in decades. And so what this means is that the population was now more overall susceptible to these orthopox viruses, including Mpox. A few years ago, there also began to be some hints that something was going on with Mpox that might pose a larger problem down the road. And we know this from the experience in Nigeria, in Western Africa. So from the 1970s until 2017, they had no cases of Mpox that were reported for 38 years. And then all of a sudden in 2017, something changed. There were 88 cases, and you can see the case numbers in other years until we get to September of 2022, when there was this large international outbreak. There was also a physician in Nigeria at the time, Dr. Ogoina, who realized that something was different, something was changing with this virus. He found that the majority of people who had the infection were adults. And this is different from the pattern with Mpox in the past, which predominantly affected children. He also found that the majority of affected people were men, and why there would be this gender difference was not entirely clear. In addition, historically, Mpox in Africa mostly affected people who had contact with animals. They hunted animals, or they were somehow working with animals. But most of the people in this outbreak were students or traders or artisans. They lived in cities and didn't have any clear contact with animals. And then also, interestingly, half of people had a rash in the genitals. And so Dr. Ogoina at the time said, although the role of sexual transmission of human monkeypox is not established, he thought that sexual transmission could be possible. And he was absolutely right. So let's fast forward a little bit until 2022, when the first US case of this infection was diagnosed at Mass General by my colleague, Dr. Nestle Bascos. She had a patient who was admitted in May, a 31-year-old man who had fever and swollen lymph nodes and a painful rash. And over the next several days, this patient received common treatments for the rash, testing for other common infections that could account for the rash, but no infection was found, and none of the treatments seemed to be working. Dr. Bascos then learned that there were some cases of Mpox that had been identified in the United Kingdom, with 4 cases. And these all seem to be occurring among men who have sex with men, or MSM, with the possibility that these were sexually transmitted. And so she decided that her patient should be tested for this. And in fact, that patient did test positive for Mpox. And you can see the screenshot there in the bottom right that you may recall from when this was reported in the news. And this is the publication of this original case of Mpox in the US, cared for here at Mass General. And you can see there on the right-hand side some published photos of the way the rash looked in this patient, with these spots that had some redness around them. And I'll show in a few more slides a little bit more about what the rash can look like with this infection. Since this first case in 2022, there have been thousands of cases in the US and internationally. And as we'll talk about as we get towards the end, this outbreak has still not fully waned. Now, as Dr. Ogoina in Nigeria noted, what we began seeing in 2022 was different than what had preceded in the years before in terms of Mpox. Classically, Mpox occurred in Central and West Africa. It affected children. It occurred only sporadically. Usually there was a history of a contact with an animal. But in this new form that we began seeing in 2022, this was predominantly affecting adults, especially men who have sex with men. It seemed to be spreading through sexual networks. And the typical characteristics of the infection were different. So historically, with the classic form of Mpox, people would get a fever, they would get swollen lymph nodes, and then they would develop this rash. But in this new form, people often had the rash first. They never had the fever or never had the swollen lymph nodes, or if those did occur, they occurred after the rash had already shown up. And then this rash was often affecting the genitals. And so I'm just highlighting here some of the typical features of the current Mpox outbreak, which began in 2022 and continues now. About half the people that have been affected are living with HIV, and having another sexually transmitted infection or STI is pretty common. That occurs in around 1/3 of people. Almost everyone with Mpox will develop a rash. So 97% of people have that rash, and around 2/3 will have fever. Now, I mentioned that the strain of Mpox that has been causing this global outbreak is the clade 2 strain. There is also this clade 1 strain, and there has been an outbreak of clade 1 as well. This was centered in Democratic Republic of Congo with thousands of cases and also deaths due to this infection. Historically, clade 1 has been more severe than clade 2. And there have been some cases of clade 1 that have spread outside of Africa, often related to travel. We've had such cases in the United States, and also there have been some cases reported of clade 1 in the US that do not appear to be due to travel itself, but suggest there is some limited community spread of this virus as well. And so this is something that we in the medical community and in public health, I think, need to be watchful for, because again, clade 1 tends to be more severe and causes a more widespread rash, and at least historically had a higher mortality rate. Now, that may not be the case with the supportive care and the hospitalization that we're able to offer here, but at least in the past, clade 1 has more likely led to death than clade 2. So what is the illness of Mpox like? Well, after someone is exposed, there is what's called an incubation period, and that's the time between exposure to when someone first develops symptoms. During that time, people have no symptoms, and this can last anywhere from 2 days all the way up to 3 weeks. Then people may have this period of having fever or swollen lymph nodes or having body aches or just feeling generally unwell. That doesn't always occur, but it can occur. And then after that, people develop a rash. And in the row at the top of this figure, you can see all these medical terms for different types of rashes. But in general, the rash moves from being a flat spot, which is called a macule, to a papule, meaning it's a bump that you can feel. It can then develop into what's called a vesicle, which looks like a fluid-filled bump. And then the classic thing that we often see when people come to care for the first time are these pustules. And those are often these bumps that have a little central point in them. And that central point is called an umbilication, which is a word for essentially a belly button, a little central divot in the middle of that bump. And then over time, those spots scab over until finally normal skin grows and heals over the spot where the bump was. Now, these bumps contain virus, and so this is in part how the infection is transmitted. If people touch or rub against one of these bumps, then they can acquire Mpox as well. So in general, people who have healthy immune systems will recover from Mpox on their own. The rash can be uncomfortable. They may have fever. But over time, the illness will resolve on its own, usually over a period of about 2 to 4 weeks. And once all the spots are scabbed over and the scabs have fallen off with intact skin underneath, we don't consider that person capable of spreading Mpox anymore. But in people who have very weak immune systems, Mpox can be more severe. And in the current outbreak, that has classically occurred in people who have HIV. And these are often people with HIV who are not on treatment for HIV and have very weakened immune systems from that condition. So in one national series of people who had severe Mpox, more than 80% had HIV. And again, these people were typically not on treatment for the HIV, and so they were severely immunocompromised because of the HIV. And these individuals, excuse me, often had really severe lesions on their mucous membranes, like they had those spots in their mouths or their throats, and that prevented them from eating, or they had them in the genitals, and it prevented them from urinating. And around a third required actually ICU level care. Now, because this illness causes a rash, I do have some photos here, and so I just want to warn you that that these photos are a bit graphic. But here are some examples of what severe Mpox can look like. People can have these really large spots that are very difficult to heal, or they can get a bacterial infection like staph or strep on top of the spots from Mpox. And that's what you see there in the panel on the right-hand side, where this person has infection that's tracking up their arm, a bacterial infection from having some Mpox lesions on the fingers. Very rarely, Mpox can infect the eyes or the brain. The eye infection can happen if someone touches an Mpox spot and then rubs their eye. And then very rarely, people can actually die of this infection. And again, that's usually in people who are very immunocompromised. So what should prompt someone to get tested for Mpox? Well, first off, people who have no symptoms don't need testing. There's actually no way to test someone who has no symptoms. So who should seek care? Who should be tested or evaluated for this infection? Well, if someone has a new illness, like what I described, fever, swollen lymph nodes, rash, especially a rash that has those kind of central divots in it, then they may need testing or evaluation for Mpox, especially if any of the following things are present in the last 3 weeks. And just to remind you, I put there another diagram of what the rash can look like. Again, it starts out as flat spots, then develops into bumps, then fluid-filled bumps, and then finally these bumps that have divots before it crusts and scabs and heals. So, certainly if someone has known contact to a person who has Mpox or is suspected of having Mpox and has a compatible illness, that would be a reason to test. If they don't know that someone they've had contact with has Mpox, but that person has a rash similar to theirs, that would be another reason to test. Another reason would be if they have an illness like this and they're part of a sexual network in which Mpox is spreading. And we also don't want to forget that there are still travel-related cases. So if someone has been in areas of Africa where there is Mpox spread, for example, then that would be another risk factor you would think of. Now, one thing that we've learned about Mpox, which we didn't know when this outbreak first started, is that people can actually spread the infection before they themselves have symptoms. And this is like many other viral infections. For example, people can spread COVID before they themselves have symptoms, or influenza, for example. So how do we know that people can spread Mpox before they themselves have symptoms? And we know this from some classic public health investigations. And I'll kind of try to explain why we know this. And it's the information is in this figure on the left-hand side of the slide. So every horizontal line here is a pair of people. The circle is one person, and the triangle is another person. And these are pairs of people in which the triangle person acquired Mpox from the person represented by the circle. Now, the x-axis here, where it says time since the end of exposure, this shows you where the circle is and where the triangle is. That shows you where each of those people, respectively, developed symptoms of Mpox. And then this shows you when they had exposure to each other. So if you look at these kind of red horizontal lines here, in all of these cases, the exposure happened before the first person, the circle, had symptoms of Mpox. And so we've learned that people can spread the infection up to 4 days before they themselves have symptoms. And then again, they may spread the infection up until the rash is fully scabbed over, fully healed, and those scabs fall off with healthy skin underneath. Okay, so if someone has Mpox, and I should also mention that this is typically diagnosed by a swab of the spots. So if a patient has an illness like this, especially if they have risk factors for it in the clinic, we will swab the spots and send the swab off to the lab. And the lab can tell us if there is the DNA of Mpox there. And if there is, then we would say that that person has been diagnosed with Mpox. So what happens then? How do we treat people who have Mpox? Well, primarily, the most important things are pain management and what we call supportive care. And that's because most people will recover on their own, especially those who have normal immune systems. So people may need to take painkillers for pain. Sometimes we can use topical anesthetics for pain. And then supportive care, so treatments for fever, treatments for the body aches, and so forth. We talked about how other sexually transmitted infections, things like chlamydia, gonorrhea, syphilis, and HIV are all common among people with Mpox. And so we test for those, and then we treat them if they're present. Are there any specific medications that can be used for Mpox? And the truth is, we really don't know. We don't know if there are antiviral medications that can be used. There are certainly some that have been used and that we do use from time to time in people who have severe infection. I'll say a bit more about one of those possible treatments, and this one is called tecovirimat, or Mpox for short. And I'll mention this one in particular because you may have heard a lot about it when the outbreak first arose in 2022. So the first thing to know is that this medication is approved by the FDA, like the other standard medicines that we use. But it's actually approved for a unique scenario and in a kind of uncommon pathway. This medicine is actually approved for the treatment of smallpox. Now, smallpox has been eradicated. There is no smallpox spreading in the community right now. But the reason that this treatment was approved was that the government wanted to have a medication that could be used in case there was a bioterrorism event involving smallpox. And so the government actually stockpiled this medication for the possibility of a smallpox event, even before the Mpox outbreak. Now, I mentioned that this drug was FDA approved, but via an uncommon pathway. What do I mean by that? Well, this was approved under what's called the animal rule. And this means that the drug was approved based on studies in animals, but no studies of whether it's effective or not in humans. And that's because you can't do a study of smallpox in humans. There is no smallpox around. And so if those human studies are not feasible or ethical, then the approval may occur through this animal pathway. It was not FDA approved for Mpox. And when things are approved via this animal rule, you cannot necessarily use them off-label. That is for a purpose other than what they were FDA approved for. And so early in the outbreak, we could access this medication in two ways. One is what's called, sometimes called compassionate use, and that's where we kind of apply, in this case to the CDC, for the permission to use this antibiotic for individual patients who are, severely impacted by this infection. We don't know if the medicine works or not, but they grant us the ability to use this medication on what's called a compassionate use basis. Then the other way was in a research study. Now, many clinicians and many members of the community said at the time, it's not really ethical to do a research study of this medicine when there are so many people who have Mpox and are suffering greatly from it. But it's important to remember that because this drug was approved under the so-called animal rule, there was no evidence or no studies in humans showing that it actually worked. And so when these studies were performed for Mpox, we actually learned that tecovirimat had no benefit. It did not shorten the duration of illness. It didn't speed the resolution of rash. In two randomized trials, one done in Africa and one performed primarily in the US, there was no benefit to tecovirimat or TPOXX. And so at this stage, we don't really know if there are specific antiviral medications that we could give to people with Mpox to help them get better faster. I would say in the rare cases now where we do have a patient who is severely ill, again, these are often people with weakened immune systems, we typically combine different antivirals. So we might use tecovirimat with another drug called brincidofovir. We don't know if that works, but it's the best we have at the moment. So this means, I think, that preventing Mpox is really important. And fortunately, we do have an effective vaccine. Now, those of you who know things about vaccines will know that there are live vaccines, and then there are vaccines that are not live. Live means they actually contain a living virus. And this vaccine that we have for Mpox is a live virus. But it is what's called replication deficient. That means it can't grow and make copies of itself inside the human body. And this is important for a reason I'll get to in a moment. The vaccine is 2 subcutaneous injections that are given 4 weeks apart. It's called the MVA-BN vaccine or the Jynneos vaccine. And it's different from, say, the flu shot, which goes into a muscle. This vaccine goes just into the subcutaneous tissue underneath the skin. So in that way, it's similar to, say, an injection of insulin. In general, almost everyone can get the vaccine. People cannot get it if they have an allergy to eggs or to 2 antibiotics called ciprofloxacin and gentamicin, and that's because those may be used in the preparation of the vaccine. And it's generally quite well tolerated. People may have pain or swelling at the site of the injection that goes away with time. That's pretty typical for many vaccines, but serious side effects are quite rare. And we've given over 6,000 doses of the Mpox vaccine in the sexual health clinic, and I'm not aware of a single severe side effect that we've had. Now, we talked a few moments ago about live versus non-live vaccines and how this is a live vaccine. We often don't give live vaccines to people who are immunocompromised because we're worried that that live virus might grow more than it should and might actually make that person sick. But you'll also remember that around half the people who have had Mpox in the current outbreak have HIV, some of whom are immunocompromised. And so we want to be able to give the vaccine to people who are immunocompromised as well. Because this vaccine doesn't actually replicate, it doesn't grow and divide in the human body, we can give it to people who are immunocompromised. And it is often effective in them as well. So who should get the Mpox vaccine? There are 2 broad kind of categories where we think of giving this vaccine. And the first is what's called post-exposure or PEP vaccination. And this is a strategy that actually harkens all the way back to the efforts to eradicate smallpox. The idea here is that we want to give the vaccine as soon as possible to someone who has an exposure to Mpox. So people could get the vaccine if they've had this known exposure, or they've had a sex partner who was recently diagnosed with Mpox, because we think that if we give the vaccine soon, say within 4 days, we can actually prevent our patient from developing the infection. You can give it up to 14 days after an exposure, and even if it doesn't prevent the infection, it's possible that it would make it milder. And so, if someone has never been vaccinated and has an exposure to Mpox, they should get the vaccine as soon as possible. The other and the much more common scenario is what I would call pre-exposure or PrEP vaccination. And this is for people who don't know that they've had a confirmed exposure, but who might be exposed. And there's a long list of people who might benefit from vaccination. So in Massachusetts, for example, gay, bisexual, and other men who have sex with men, and also transgender and non-binary people who've had an STI diagnosis in the past 6 months, or who have more than one sex partner, or in general, people who've had sex at a commercial sex venue or a public event where Mpox transmission has occurred, or who exchange sex for money or other items, people whose sex partners have any of those characteristics, people who anticipate experiencing any of those scenarios but who haven't had those scenarios yet, people with HIV, and then also people who work with these viruses in a laboratory, like in a clinical setting or in a research setting, can also get the vaccine. And most recently, added to this list has been people who are going to travel to an area where there is an Mpox outbreak, for example, in Africa, and who anticipate sexual activity there. Now, people may not want to call up a clinic and say exactly which of these characteristics apply to them. And so in Massachusetts, it's recommended that we give the vaccine to anyone who requests it, that simply asking for the vaccine is a sufficient indication for it. How good is this vaccine? Well, we've learned that the vaccine is effective and that getting both doses that are recommended is better than getting just one. The vaccine will reduce someone's chances of getting Mpox by 68% after one dose of the vaccine, and then 89% after 2 doses. And similar to some other infections, we've learned that even if the vaccine doesn't fully prevent the illness, it makes it much milder than it would have been otherwise. We see that, for example, with vaccines for influenza and vaccines for COVID, and now we're seeing it with vaccines for Mpox as well. So for example, compared to people who've never had the vaccine, those who have Mpox, despite full vaccination, are less likely to be hospitalized. They are less likely to die of the infection. They're less likely to have systemic illness, such as with fever and so forth. They're less likely to have headache. And they also have fewer skin lesions. In someone who's never been vaccinated, usually there are 4 different regions of the body that are involved with the rash. In someone who has been vaccinated, on average, just 1 area is involved in the rash. And I would say in our experience caring for people with Mpox, we found that those who have been vaccinated and still get it often have a very limited rash. It's not as painful as it would otherwise be, and it often gets better faster than in our patients who've not been vaccinated. I should mention that the rash from Mpox is scarring, and so trying to reduce the amount of area involved in the rash and prevent the rash is important for people's health. Now, there are often some common questions about vaccination. So one, should fully vaccinated people receive a booster dose? And there's not a recommendation for a booster dose now. There is some data showing that people who've had the standard 2-dose series will mount a response against Mpox even years later. One exception to this is people who work in an occupational setting with the Mpox virus. And for those individuals, a booster dose is recommended. The reason is that they may have very unique types of exposures. For example, they have a beaker full of Mpox, and the beaker crashes and breaks and spills, and they have a massive, large exposure. And so in those scenarios, booster doses are recommended for those people who have occupational exposures, and those can be given as soon as 2 years after the initial vaccine series. What about people with prior smallpox vaccination? So although widespread community vaccination for smallpox ended decades ago, some pockets of the population have continued to get smallpox vaccines, for example, in the US military. We've learned actually in a study of veterans that those remote smallpox vaccines in people in the military do actually reduce the likelihood of Mpox. But that protection is not absolute. And so it's recommended that people who've had, smallpox vaccination in the past, such as with military service, that they still get the Mpox vaccine if they're otherwise eligible. And then what about people who have had Mpox itself? Do they need the vaccine? And the answer here is different than the way we approach many other infections. So for example, people who have had the flu should still get the flu vaccine. People who have had COVID should still get the COVID vaccine. People who've had shingles should still get the shingles vaccine. But Mpox seems to be different. When people have the infection themselves, they seem to have long-term immunity to getting the infection again. And cases of someone getting the infection more than once are extraordinarily rare. And so right now, no vaccination is recommended for people who acquire Mpox. And if someone gets the first dose of the vaccine and then gets Mpox before they get the second dose, then no second dose is required. Now, I think it's important to highlight that the Mpox outbreak continues. The highest case counts were seen in 2022, when thousands of people were affected, and the number of cases has gone down dramatically since then. But Mpox has never fully gone away. And this is from the CDC website. It shows the case counts in the US from January 1st of 2025 to December 31st of 2025. And you can see that there's essentially no week when there were no Mpox cases reported in the country. And there did seem to be an uptick in cases last fall. We certainly saw this in our own clinic, and also learned about statewide data in Massachusetts showing that there was an uptick in Mpox cases this past fall. The majority of people affected had not been vaccinated. And interestingly, many of them were fairly young. And one thought is that these individuals may have been in their teens in the 2022 outbreak, and so kind of weren't part of the vaccine efforts at that time. And it's a reminder that there may always be people who are kind of aging in to the populations in which this infection may be spreading. And so vaccination needs to be an ongoing effort, and not just kind of a one-time large-scale effort, such as what occurred in 2022. So we've continued to see Mpox infections in our clinic, and I think we've diagnosed the last one at MGH within the past week or so. So this outbreak does continue, and there are still many people who could benefit from vaccination. So in summary of this, people with Mpox typically develop a rash, often in the anal area or the genital area, but the presentations can vary. Most people with Mpox will recover with supportive care only. The optimal treatment for those who have severe Mpox is actually not known, but we may try to combine several different antivirals in that scenario. And vaccination is the most important preventive strategy. And fortunately, we have a vaccine which, after 2 doses, is 89% effective at preventing the illness. And if the illness does occur despite vaccination, it tends to be milder than it otherwise would have been. I am now happy to take any questions or comments that you have. And I see one question about if there have been cases of Mpox in the US since 2022, why don't we hear about it in the news? Great question. I think it's because the total number of cases has gone down, and so it's been, less present in the news. But I think it's really important that people know that Mpox is still there, and that they pursue the vaccine if they're interested in receiving it.
We have another question here. If someone gets 2 doses of the Mpox vaccine, will they need to get the vaccine again later in life?
So far the answer to that is no. We don't think a booster dose is needed after those first 2 doses for people who have exposures in the community.
We have another question. It was a follow-up to the first one you answered, I think, and it says, can Mpox be dormant and become in the active state if something triggers it?
That's a great question. We don't think it can be dormant and then become active. That's unlike, several other infections that we think about. One thing I would say, though, is that we've learned that there may be a small number of people who can have Mpox and never have symptoms. They do clear the virus on their own. It doesn't stay dormant in their system, but they may never have symptoms themselves. And we've learned that because there have been studies, I'm thinking of one study from Europe, where people went to a sexual health clinic and had testing for common things like chlamydia and gonorrhea using swabs. And in this study, they actually took the swabs and they kind of secondarily tested them for Mpox. And they found that a small proportion of people actually tested positive for Mpox. And they then followed up with those patients, and some of them never had symptoms and never developed symptoms. And so we think it's possible that a small number of people may have wholly asymptomatic infections, but we don't think it can be dormant and then reactivate. And it looks like there might be another question. What role do community leaders play in promoting accurate, non-stigmatizing, and equitable information about Mpox? I think that that they play a really crucial role. As one of the other questions highlighted, Mpox is not in the news right now, but we know that transmission continues and that the vaccine is important. And so I think community leaders can help spread the word that this is something people can do to benefit their health. I should also mention cases of Mpox have disproportionately affected Black and Hispanic individuals in the US. And so I think trying to ensure that vaccine efforts can address those disparities is really important. In the uptick in cases that I showed you in the fall of 2025, the people who were disproportionately affected in Massachusetts were Black and Hispanic. And so I think community leaders can play a really important role in making sure that all of our communities hear about this vaccine and know ways to access it.
Great, thank you. We have another question, and it says, if they don't show symptoms, can they be considered infectious?
So we know that people can transmit the infection before they themselves have symptoms. In people who never have symptoms, who are wholly asymptomatic, I think we don't know for sure, but we do, as I said, know that people who can transmit before they themselves have symptoms.
And while we wait to see if there are any additional questions, do you have any final thoughts you'd like to share with the audience?
I guess I just want to share, I hope that people consider this vaccine if they think they might benefit from it. It's very easy to get. We offer it in the MGH Sexual Health Clinic. There are many places around Boston and around Massachusetts where people can get the vaccine, and in other states as well. I think that would be the main thing.
Thank you. I also entered in the chat the Blum Center website to access the recording. So if anyone's interested, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. All right, so I don't see any additional questions, so I think it'd be fine to end a few minutes early. Dr. Ard, thank you so much for spending the hour with us. This was extremely helpful.
Thank you. Take care.
And for everyone joining us today, thank you so much. Hopefully you found today helpful as well. Take care, everyone.